This is a skills presentation on insulin infusions by Allison Wary for course Nurse 455. Insulin was discovered in 1921 at the University of Toronto by the four men on the screen there. It was a collaborative effort that took many years, numerous studies and trials to purify and pinpoint the desired effect of the medication. Now, the medication insulin is actually an endocrine peptide hormone that is used primarily for blood glucose control and for the treatment of hyperkalemia. It binds to insulin receptors on the plasma membrane of certain cells and stimulates the uptake of glucose into the cells from the blood, thus lowering the serum levels. A good way to think about how insulin works is that insulin is the key that opens the cells, allowing the glucose to enter them. Many conditions that cause the need of insulin can be thought of as starvation in the face of plenty. So there's plenty of blood sugar available, but none of it can enter into the cells. Insulin has been divided into 4 categories. You have your rapid-acting insulins like Lispro and Aspart. They take action in about 5 to 10 minutes. They peak in action at 30 minutes, and they last for about 3 to 5 hours within the body. They are typically used in conjunction with longer-acting insulins and before meal times to manage levels prior to eating. Next, you have your short-acting insulins, such as your regular insulin, so Humulin R and Toronto. They begin to work inside the body in about 30 to 40 minutes. They peak at 90 to 120 minutes, and they last for about 6 to 8 hours. They are typically taken at meals, so 3 times a day, but it is important in those patients that they eat within 30 minutes so that they don't become hypoglycemic. The most common that we use for insulin infusions is an intermediate acting insulin, so that is your NPH and your Humulin N. It takes action in about 1 to 4 hours and peaks in 4 to 8 hours in the duration of 8 to 12 hours. It's used twice daily subcutaneously for patients at home for a basal dose and long-term management of glucose level maintenance. In a hospital setting, again, we use it for an IV insulin infusion. That gives us the best control, as well as when patients are in a state of hyperglycemia. We do not want to lower their blood sugar too quickly because it can cause metabolic imbalances. The last insulin category here is your long-acting insulins like Glargine and Lantus. So they begin to work in 1 to 2 hours, and they provide a plateau mechanism of action for 12 to 24 hours. So that is typically the insulins that your patients would take at bedtime after their meals, and that provides them a sustained maintenance overnight and into the next day. The indication for initiation of an insulin infusion typically comes from a patient who is in a hyperglycemic state, meaning their blood sugar is far too high. And that can be caused from a range of conditions such as diabetic ketoacidosis, HHNS, critical care illnesses, post-cardiac surgeries, a prolonged NPO in insulin-deficient patients, sometimes in labor and delivery, strokes, patients receiving TPN therapy, post-MI or cardiogenic shock, hypoglycemic states secondary to glucocorticoid therapies, and post-organ transplant patients. There are no absolute contraindications for the initiation of an insulin infusion if it has been ordered for the treatment of a patient's state. There should be special consideration in patients who have hepatic failure, renal failure, insulin sensitivities, are hypokalemic or hypoglycemic. Some required equipment for initiation of an insulin infusion include, of course, a physician's order, an infusion pump, as it is a high-risk medication and needs to be delivered at precise dosages, an infusion set, both primary and a secondary line, the IV fluids per the physician orders based on the patient's state, IV access, insulin per the physician's orders, PPE per your patient, flushes, of course, glucagon just in case, Dextabs or juice depending on your patient's level of consciousness and their tolerance, dextrose 50 ampules, that will be based on your pre-printed orders and site-specific, antiseptic swabs, as with any infusion, a glucometer and your associated supplies for that, for monitoring your capillary blood glucoses at the bedside. Labels to label your lines, as it is, again, a high-risk medication. And then your site-specific documentation for management of insulin infusions and your glycemic records. So administration of an insulin infusion is recommended to reconstitute a concentration of 1 unit per mil of insulin per physician orders into a 100 ml mini bag of normal saline, lactated ringers, or normal saline with dextrose 5%. Intravenous is the preferred route of an insulin infusion for a hospital setting, as it has a fast acting time with a short duration of action, and it is easier to control as the patient fluctuates. It's recommended that a pump is used, again, as it's really important to ensure an accurate dose of administration. You want to follow your organization's protocols for interventions in hypoglycemia during these insulin infusions, as it is, of course, a side effect. An example here being Northern Health and our DKA PPO guides the nurse to stop the insulin infusion and administer 25 mils or half an ampule of D50 for a serum glucose of less than 8. And the ICU insulin infusion PPO guides for a blood glucose of less than 4 give 25 mils, so half an amp of the D50 as well. And of course, the blood sugar is measured in millimoles per liter. So insulin is a high-risk medication. You want to make sure that you're following site-specific policies and procedures regarding administration. So doing your double checks, making sure you're labeling things, having someone co-sign, having 2 nurses at the bedside in initiation of the administration. Just make sure you're familiar with what your current health authority is requiring of you in documentation for that. And then for monitoring, you want to do a serum glucose Q1 hour, so that may be titrated to Q2 to Q4 based on how the patient's responding to your interventions, as well as may be considered to switch to a capillary glucose once the blood sugar has reached a desired level. You want to do your vital signs Q1 to 2 hours, as tachycardia is very common with this, as well as you want to see if they're febrile, afebrile, and hemodynamic stability, of course. You're going to do lab work upon initial presentation of your electrolytes, your venous blood gases, complete blood count, and a urinalysis. And then Q2 hours of your electrolytes and venous blood gases. So you want to really be aware of your anion gap, your sodium, your potassium, and of course your random glucose levels. And this will be dependent on your specific site and health authority, so just checking those again before you administer anything. Side effects include hypoglycemia, decreased level of consciousness, confusion, tremors in all 4 extremities, nausea, vomiting, hypokalemia, and hyponatremia. Just a clinical pearl is to request an order for an antiemetic such as ondansetron or dimenhydrinate, as patients often get quite nauseous in this state. Here are the 2 PPOs we have most available within Northern Health, the one for DKA and the insulin infusion, which is exclusively for the ICU within Northern Health. So as you can see, both have guides for what labs to order, what kind of monitoring to do, and then tables for maintenance of the insulin infusion and how to titrate or manage it. Thank you for listening to my presentation, and I just want to encourage everybody to really get familiar with your site-specific PPOs regarding management of hyperglycemia and insulin infusions, and good luck, everyone!